So first of all, I just want to introduce myself. My name is Christine Zarowski, and I'm actually the sexual health clinician for the Prostate Cancer Supportive Care Program. I've been a sexual health clinician now for probably about 18 years, and I've actually joined this program in 2013. So come June will be my 4 years with the Prostate Cancer Supportive Care Program. I know that this is a time of change and challenges, not just physical, emotional, but psychosexual as well. And I just want to, applaud you all for taking the time to come and listen to this presentation. We feel knowledge is power, and what we hope is that through this presentation that you will feel empowered, but also enlightened and recognize some guidelines about how to navigate this prostate cancer experience. This next slide actually highlights the funding that the PCSC program has received, and actually it's coming from the physicians and staff of Vancouver Prostate Centre and the British Columbia Cancer Agency. Initially, the support that we received was from the Specialist Services Committee, and we've also received support from British Columbia Ministry of Health. And you can see all the other organizations that have provided support. Plus, we also want to thank the individual donors because, again, with the monies, we're able to create the service and provide the help that people need. So the program itself, again, it was established in 2013. Basically, it's meant to provide supportive care for both the patients and their partners from the time of diagnosis onwards. Individuals that are in a partnered situation, I actually identify prostate cancer as being a couple's disease. The man might have prostate cancer, but it actually can affect partners as well. When we think about the PCSC program, it's both a supportive care program and also a research initiative. There's a set of modules, which I'll explain a little bit more about, that actually provide support beyond cancer treatment itself. And most of the modules are preemptive and have educational themes, and patients choose which modules would be of interest for them. So basically, we're looking at trying to empower you with the knowledge, but also help to relieve the stress that you might be experiencing during this situation. Okay, so basically there's, again, 6 modules that we see. The first module deals with the introduction to prostate cancer and primary treatment options. The second module, which I'm related to, managing the impact of prostate cancer treatments on sexual function and intimacy. I'm going to explore that a little bit further, a little bit more in depth in a few moments. The third module, lifestyle management, focuses on nutrition and exercise. We have Sherry Patterson that provides educational sessions about every 3 months, and we have Sarah Weller, who's our exercise physiologist, that also does an education session but also has clinic appointments as well. The fourth module deals with recognition and management of treatment-related side effects of androgen deprivation therapy. That's a type of another type of therapy for prostate cancer. The other term for that is ADT. With that particular module, there's actually a resource book that's used, and again, it's really helpful for men going on androgen deprivation therapy, but it's also helpful for partners to understand what are the potential side effects. The fourth module, which is run by Marcy Diane, she's our pelvic floor physiotherapist. And because what we do find is that there's certain prostate cancer treatments can actually affect bladder function. So things around urgency or frequency or urinary incontinence. So pelvic floor strengthening is something that's very important. And the sixth module that we have deals with emotional well-being or emotional health. So looking at counseling services and group therapy workshops. That's run by Kevin Lutz. And if a man can be lovely, Kevin's lovely. So again, you can see that a lot of these programs or modules are interrelated and to help support the overall well-being of the individual and the partner as well. So the objectives, what I want to talk about tonight, first of all, I want to put all fears, set aside all fears, because I will not be asking any personal questions around your sexual health here. If you come for a clinic appointment, yes, I will be asking you personal sexual questions there. But so tonight, as you see, there's lots of objectives that we're going to go through, and like I said before, the resource package that you have can actually help reinforce what I'm going to be talking about. So we're going to be looking at understanding the elements of the prostate cancer supportive care program's sexual health service. We're going to identify general concepts around sexual health and sexuality. We're going to look at understanding the concept of sexual adaptation post-prostate cancer treatment, review basic anatomy of the prostate gland, the penis, and erection, identify how treatments for prostate cancer affect sexual function, recognize the factors that can affect the recovery of erections, understand penile rehabilitation and why it is important, identify options for supporting erections for sexual purposes, and understand that you are still a sexual person and can enjoy the different dimensions of intimacy. I probably would have more objectives, but I ran out of space. So again, lots of things that we're going to be covering tonight. So when we think about the sexual health service, basically there's two routes for patient assistance. The first route is actually what's happening tonight. This is an educational session. So basically, this is for individuals that are newly diagnosed with prostate cancer or they're within 6 months of their primary treatment. Basically, what we're going to be doing is talking about the sexual, well, I just went through all the objectives so you know what's going to happen tonight. So one of the things I do want to say is that there is going to be a note or a letter sent to your family doctor or referring physician, just indicating that you've attended this session. It's part of our process link to make sure that we don't lose people, because a lot of times in our medical system, people fall through the cracks. If for some reason you do not want to have a letter sent to your family doctor or referring physician, just let me know or let me need to know, okay? The second part that happens is individual therapeutic clinic sessions. So this is actually going to be either with me or it's going to be with our sexual medicine physician, who's Dr. Stacey Elliott. So it's during those clinic sessions that we actually look at specific areas of changes around your sexual health or your sexual functioning. And what we do is we develop what is called the SHRAP, Sexual Health Rehabilitation Action Plan. This is something that's incorporated into a report. It's also something that I like to share with individuals as well. Because again, sometimes it's hard to remember all the details about an appointment, so having some guidelines is quite helpful. Okay. And then the other thing is that we have for couples that have actually come to the clinic, they're actually welcome to attend an intimacy workshop. And what that intimacy workshop is that sometimes going through this prostate cancer experience, sometimes couples will get on different pathways. And it's hard to kind of focus on the different aspects of intimacy. So not just the sexual intimacy, but the emotional intimacy and the relational intimacy. So where the workshop comes in handy, it actually looks at different activities, tools, and skills to actually help enhance or bring back those levels of intimacy. So the other part of our service is that when you do come to a clinic, it's important to have a doctor's referral. So in this particular situation, you either might already have a clinic appointment set up. It's not compulsory, it's more if this is something that you want to follow through. Or if you don't have a clinic appointment, but you've already had your primary treatment, you can actually give Manita a call, and she would make arrangements to have a clinic appointment to see myself or Dr. Stacey Elliott. If you don't know what your primary treatment is, and you do want to have a clinic appointment, once you find out when your primary treatment is scheduled, that's when you would give Manita a call, and again, we would set up a clinic appointment. The services that are associated with our program are free. So again, coming for a clinic appointment or coming to the couples intimacy workshop or the other modalities, again, it's included in our program. So again, following the clinic appointment, a consultation note will be sent to your referring doctor and to your family doctor. Also, we've set up a clinical pathway. So as long as you need to be seen or that you have some sexual health goals, we will continue to see you. So a general example might be meeting at 3 months, 6 months, 9 months, 12 months, 18 months, etc., depending on what's happening in your situation. Okay. The appointments can either be in person or they can be done through teleconference or phone appointments. And I also do communication through emails as well. Okay. So one of the things that we do highlight is that we take a biopsychosocial approach, meaning that your sexuality not only is about sexual function, but other dimensions as well. Okay. So basically what we have areas to help with erection function, there's a couple modalities that we've actually set up. One is a penile injection clinic. This is something that I run. I won't give you details about it right now because it's not permanent at this point. But the other element that we have is erection or vacuum erection device clinics. And these are actually run by a gentleman by the name of Lou Rue. He actually broke my heart because he used to be here in this building, but he moved to Kelowna. But he actually comes back about once a month and sets up a clinic where individuals or couples can come learn a little bit more about the vacuum erection device. Actually, it's a very good clinic. I went to the clinic with my mustache, but I did not get an erection. But men will. The other thing that we actually assist with, we look at things like sexual drive or sexual appetite or libido. We look at if there's changes with ejaculation or orgasms. We also look at if there's changes with mood or emotions around being a sexual person or around your sexuality. And we look at the effects of sexuality and relationship changes, possible changes with your partner as well. So again, looking at the biopsychosocial approach. So here, I just wanted to show some of the sexual health service core principles that we focus on. So things like confidentiality and permission. Again, this is something that's very intimate, and it's not every day people are feeling comfortable talking about these areas. So again, we have a lot of respect around that. We also look at comfort. When I think about this whole process, it's not something that's completed in a couple of months. It actually can take years. And during that time, people will go through different kinds of stages, okay? So again, looking at the comfort level at that time of interaction. Level of readiness. Again, like I said, it's a process that individuals go through. We have equality for gender diversity and preference. Single or partnered men are both readily welcomed, are equally welcomed into our program. Plus, we always encourage partners to attend the sessions as well. Again, while the focus is on sexual health aspects, we might address other elements that might be interfering, such as psychological elements, if there's anxiety or depression, or if there's other medical conditions. For instance, if a man has poor sleep hygiene, we might look to see whether or not there's sleep apnea, for instance. So basically, we maintain the philosophy that maximizing general wellness improves overall sexuality. The next couple of slides, I wanted to talk a little bit about sexual health and sexuality. And sometimes, it's very interesting. It's very much part of being human. It's part of our world. But sometimes we just don't really pay a lot of attention to it. Or it's hard to identify, what does it really mean? So here we have a couple of definitions. The first definition is coming from the World Health Organization. Basically, it's stating the integration of the physical, emotional, intellectual, and social aspects of sexual being in ways that are positively enriching and that enhance personality, communication, and love. When we think about sexuality, it basically comprises of all the feelings, attitudes, and behaviors that contribute to a person's sense of their self, both publicly and privately. Publicly is how you're presenting yourself to the world, and of course privately is how you're sexual, either with yourself or with a partner. One of the things that we also recognize is that it spans over a lifetime. It's not just like for the adult years, right? It's from the moment that we're born to the last breath that we take. I actually included this. This is actually, it's called the Wheel of Sexuality. This is something that was composed by my original team that I was involved with. And what I like about this is that it actually shows the biopsychosocial aspects of sexuality. When we look at the middle part, it says sexuality is like gender identity and gender expression. Corey Silverberg is one of the sex therapists that I've worked with in the past, and what he kind of defines it as is sex is what we do, and sexuality is who we are. So when you think about it, you can see all the different kind of elements that are involved with this. One of the things at the top, values and beliefs. And this is something that is very, very important to how we see ourselves as sexual individuals. A lot of times these are guided by our culture, our upbringing, our life experiences. But one of the things that I always want people to look at is whether or not the values and beliefs are influenced by societal myths. Okay? So there's lots of different types of myths out there. These are just some examples. What we see here, men should initiate sexual activity. Sex should be spontaneous with no planning, no talking. Good sex requires orgasm. Sex education is only for disease prevention. Sex is for young people. If that was a reality in life, I'd be pretty upset about that. So again, when you're thinking about your beliefs and values around your sexual self, you think about whether or not they're being impacted by these myths. Okay? We actually, in our society here, it's very, very much phallic focus. I remember reading an article by Mitch Tepper, and it was actually, Mitch Tepper he's again a sex therapist. He's also a man with a disability, he has a spinal cord injury. And he was doing an article about perspectives of men in relationship to chronic illness. And when he was looking at the pressures of men in our society around masculinity, it's very, very challenging. In fact, the standards are so high that even if everything is optimal, it's very high to reach those standards of masculinity. So again, the pressure to be a certain way is very, very significant in our culture. When we think about sexual adaptation, what this is, the process of sexual adaptation following prostate cancer treatment is complex and warrants the need to apply the principles of acceptance, flexibility, patience, and persistence. Right now, I probably have about 800 men in my life. And I've worked with men and I've worked with couples. And one of the things I find that's very successful for sexual adaptation is recognizing these principles. And it's really important to continue to remind yourself about these principles. I'll remind you about these principles. The process of sexual adaptation includes grieving loss and moving forward with new ways of being sexual, along with redefining one's sexual self-view and corresponding sexual values. For some individuals, sexual rehabilitation or penile rehabilitation may or may not be a goal at this point, or it might be a goal. So again, when we think about that, with sexual adaptation, like I said, it can include sexual and penile rehabilitation, which is a philosophy of care applying restorative and rehabilitation principles to adapt to limitations, maximize potential while remaining open-minded to possibilities. So a lot of things that we see in sexual adaptation, it's enhancing sexual knowledge, it's developing a positive sexual self-view, which means examining the elements around masculinity or body image. Also, it's redesigning and renegotiating sexual behavior and activity. I think you get what I mean, right? So again, those are some of the elements that are really important for sexual adaptation. So things to remember is that you are still a sexual person even with sexual function changes. I remember when I first started in this particular career, I was reading an article, it was a research study that was put back in 1992. And basically, there's a question that was put out that says, do you have concerns around your sexual function? And there was over 1,800 females questioned and over 1,400 males that were questioned. And 43% of the females came back and said, yes, I have concerns around my sexual function. And about a third of the men came back. And one of the things that the researchers felt at that time is that this was probably an underestimation. Because a lot of times if there's changes with sexual health or sexual function, a lot of times people feel they're the only ones going through this. And they feel that it's very abnormal. But in essence, sexual changes or not complications, but challenges are very, very common. And so when the research actually reviewed this a little bit further, they found that a lot of these changes actually could be remedied. And so one of the other things that we find in research is that a lot of times healthcare professionals will say, you know what, if there's a concern or if there's a problem around this person's sexual health or sexual functioning, they'll bring it up. But literature shows that a lot of times patients want the healthcare professional to bring it up. So again, there's a breakdown in that communication. The other thing that we see here is your sexual life is your own and it is you, and if you have a partner, it's up to you should decide what is comfortable and what is important for your sexual life. And then again, living the experience of prostate cancer, it creates opportunity to redesign your sexual life. I remember one of the quotes I had from one of my patients came back with, "This experience has given me license to be intimate with myself," which I thought was something very powerful and very, very much around permission giving, allowing yourself to explore. So this next section, I just wanted to talk about some basics around the anatomy of the prostate gland. And I know that you've probably all looked at this, but sometimes just reinforcing it helps to provide a little bit of clarity. So basically what we see is that the prostate gland is situated behind the pubic bone, right here, right? It's in front of the bowel, it's underneath the bladder, and the urethra, which is a passageway for urine, runs through the prostate gland. The size can vary depending on the age of the male or whether or not there's benign prostatic hyperplasia or whether or not there's prostate cancer, right? And also with the function of the prostate gland is that it provides part of the nourishing fluid, semen for the sperm. So that's some general things around the prostate gland itself. The next picture that I've put up here, it actually displays what is called the nerves of Walsh. This is this area right here. This is the bladder, this is the prostate gland. And there's these nerves right here, which are also known as the cavernous nerves. And what the cavernous nerves do is that they help to control the erections. Okay? And actually, the nerves are actually one element of what helps to control the erection, which I'll explain a little bit more in a few moments. The next picture that I have here is actually some information about what is in the penis. So basically, when we think about the penis, it actually there's 3 tubes in it, okay? So what we have here, this is the urethra, and these are called corpus cavernosum, okay? So these are known as the erectile bodies within the penis. Within the penis, there's little tiny spaces in the corpus cavernosum. There's these little tiny spaces called sinusoids. You can see them right here. These are sinusoids, okay? This is the erect penis. This is a flaccid or relaxed penis. The sinusoids are actually surrounded by what is known as endothelial tissue and smooth muscle. So what happens is that when the smooth muscle relaxes, it opens up the sinusoids, allowing the blood to come into the penis to help create the erection. So the elements that are necessary for creating an erection, there has to be adequate blood supply. There has to be sexual arousal, which stimulates the release of neurotransmitters from the nerve endings. So things like testosterone, for instance. But there's a whole bunch of lots of other chemicals that are released as well. It causes this chain reaction to allow that smooth muscle to relax. So, and then, like I said before, then the blood comes into those spaces to help create the erection. And then around the penis itself, there's something that's very similar to saran wrap. It's called the tunica. And what happens is when the penis gets engorged, the tunica tightens and it closes off the blood vessels to help maintain the erection. Okay. So what do we need for erections? Is that you need healthy blood vessels, healthy nerves, and healthy erectile tissue. So those are the things to keep in mind. So this next section, what I wanted to talk about was look at some of the primary options for prostate cancer treatment and see how they actually impact different elements of sexual function. So the primary treatments that we'll look at is active surveillance. So again, there might be indication prostate cancer is present, but there's no need to act on treatments at that point. The next is the open or robotic radical prostatectomy, again, which is a surgical removal of the prostate gland. Then there's brachytherapy, which is a type of radiation therapy where there's radioactive pellets that are inserted into the prostate gland. External beam radiation, and then finally androgen deprivation therapy, or the ADT. So the areas that I kind of wanted to review is things like sexual drive, or the sexual appetite, libido, erections, orgasms, ejaculation, climacturia. Has anybody heard that term before? Climacturia is a release of urine at the time of orgasm. Okay. Penile structural changes, and then of course maybe alterations with sexual self-view and body image. Okay. So when we think about active surveillance, we see that there's no direct impact on sexual function. However, anxiety around being diagnosed with prostate cancer can sometimes interfere with sexual interest in erections. I remember there was one couple. The gentleman had been on active surveillance for maybe about 3 years or so, and his partner, who's his wife, supported him during that time. But during that whole time, the anxiety that she had, knowing that her husband had prostate cancer, was extreme. And so when he did have intervention or treatment for his prostate cancer, she shared with him about how stressful this had been. And he didn't know that. And so one of the things I always come back to say to individuals or couples is that it's really important to communicate. Because no matter how long individuals have been together, you never can read each other's mind. So in this particular situation, the impact was more on the partner than on the gentleman. Remember, I talked about it being a couple's disease, right? So when we think about prostatectomy, is that what we see in the beginning is that the acute recovery phase may interfere with sexual drive. I mean, a man has just had surgery, and usually maybe that could take 8 to 12 weeks or more weeks to just recover from that. Having the anesthetic come out of the body, dealing with the surgical wounds, etc. So one of the things that we do see is that there can be penile shortening, and so what we find is that with the nerves. The cavernous nerves, they actually have two functions, relaxation and contraction. And there's almost like an increased tone that occurs where we see that the penis sometimes gets more withdrawn up into the pelvis. Sometimes people thought that, well, because the urethra runs through the prostate gland, once you take the prostate gland out, you're taking part of the urethra, but basically what they do is they take the bladder neck and they bring it down to connect to the urethra. So there really isn't that much of a drawing up. The other thing that we see is, again, the climacturia, which could be the release of urine, there could be the urinary incontinence, and also the frequency. And so that's one of the reasons why it's really important to have a good pelvic floor. So doing those pelvic floor exercises. And that's where it's really important to be able to connect with Marcy around that. What we see with the erectile changes, they're usually immediate, okay? And what happens is that with prostatectomy, and I'll talk a little bit more about this, is that they can do what is known as nerve sparing. But even in nerve sparing scenarios, the nerves, they go into what is called a neuropraxia, or a shock phase. So again, when I first started in this role, I actually asked to see some surgery. So I saw the robotic, I saw the radical prostatectomy, and basically what happens is that those cavernous nerves, or the nerves of Welsh, anatomically, surgeons will know where they are, but it's not like one single nerve. It's like a webbing of nerves or a spray of nerves. So again, when they're, it's almost like peeling layers of onion away from the prostate gland. So when they're doing that, again, the nerves are exposed to different types of heat or tension or pulling, etc. And so that's why they go into a shock phase. So a lot of times with nerve sparing, again, that's dependent on the characteristics of the cancer. So again, the first objective for the surgeon is that when he goes in, he wants to get rid of that prostate cancer. If there's any indication that the prostate cancer has moved beyond the prostate wall, then again, he has to do a wider excision, which might mean the removal of those cavernous nerves. The other thing that we see is ejaculation. Because the prostate gland and the seminal vesicles that are removed during prostatectomy, those are the glands that provide the fluid for the sperm. So there won't be any ejaculation, okay? Sometimes men still might have a little bit of fluid that's coming forward that might be urine, or it might be fluid that's coming from what is known as the Copper's gland. That gland actually serves to lubricate the urethra before ejaculation. Orgasm. So I have a question. If a man is not able to have a full erection or has no erection, do you think that they can be orgasmic? Yes, they can. So that was one of those myths, thinking that in order to be orgasmic, a full erection has to be in place. But the nerves that control orgasm and the nerves that control erections are two different things. Sometimes men might, in the beginning, they might have some discomfort with orgasm, some pain with orgasm, but generally what I'm hearing is that about 40% will say the orgasm seems pretty much the same. 40% of men will say, you know what, it's different but still pleasurable. And then there's 20% of men that will say it's even better. So that they even found some of the secrets of women. They become multi-orgasmic. So again, so orgasm is possible. And so again, the nerve sparing are not necessarily, I kind of explained that a little bit about what is the determining factors whether or not that's going to occur. When we think about nerve sparing, again, it might be a partial nerve sparing, or it might be bilateral nerve sparing, or it might not, there might be a non-nerve sparing procedure. And actually, even in situations where it's a non-nerve sparing procedure, sometimes there can be some cavernous nerves left behind. So again, like I mentioned, the nerves, there's just not solo nerves, it's a webbing or a spray of nerves. Even with the best nerve sparing technique cannot guarantee preservation, okay? Damage, I talked a little bit about that. That could be related to stretching or heat, right? So those types of things. And nerve recovery can actually take up to 4 years. And that's the thing where that patience and persistence comes in. But basically, your body has a final say of what's going to be happening with that recovery. All right, so the next area that I wanted to talk about is a little bit about radiation, which is either external beam radiation or brachytherapy. So basically what we see with the sexual function, there tends to be a delay. So like with prostatectomy, usually we see a change right away with erectile function. With radiation, there tends to be a delay. In the acute phase of receiving the radiation, sometimes sexual interest is decreased because some men complain of fatigue when they're going through the radiation. The other thing is that we see what happens through radiation is that there's irritation and inflammation. And this is not only for the nerves, but it also can affect the blood vessels and also the penile tissue as well. Again, we can see penile atrophy or the shrinkage of the penis. And one of the reasons why that can be occurring is that if there isn't blood coming into the penis on a regular basis, it's not getting nourished. Okay, the erectile bodies are not getting nourished. Sometimes with the ejaculation, it still might be present, but over time it will diminish. And also in the beginning phases, there also could be blood that can be noted with the ejaculation. Again, the similar things around bladder function can occur in regards to urinary incontinence, climacturia, and frequency. A lot of times with radiation, I hear more about urgency and frequency. Okay? And also what can happen is there can be changes to the bowels. So again, if the radiation is affecting part of the bowels, more so maybe with external beam radiation, you might see changes such as diarrhea or urgency with bowels, things like that. And some men actually complain of what they call as radiation burns. So there might be skin changes that can happen. And some men, when they go through radiation, they don't have any of the side effects. So it's kind of a toss-up of how your body can adjust with that. With the next area that we have here, talking about androgen deprivation therapy. So again, this is a type of therapy that is used to depress testosterone. Okay, so testosterone is kind of like that chemical that sort of gives you that zing for life. Is also something that's very important for sexual drive. It's also something that's very important for creating erections. So one of the things that's important to recognize is how long a man might be on ADT. The longer that a man is on ADT, the harder it is for the body to rebound back. So it's harder for the body to start producing the testosterone again. So what we see, there could be a decrease or loss in sexual drive. And so what that means is that because there's no testosterone there, is that a person or a man might become what we say sexually neutral. A lot of times women, when they go through menopause, they just might not have that innate or that sexual drive as well. So even though it's not on the radar, a man can still enjoy sexual pleasure. I use the analogy of food, for instance. Sometimes we know it's important for us to eat, but we're just not hungry. But once we begin to eat, we experience the food and with all of our senses, and we're like, this is actually really good. the same thing can happen with sexual activity as well. Right? Once you start enjoying it or experiencing it, then the pleasure can come. We also see that there can be challenges, again, with achieving and maintaining erections when a man is on androgen deprivation therapy. And also what we see is changes with orgasm and ejaculation. Sometimes a man can still be orgasmic, but what happens is to get to that, what we call the orgasmic plateau, he might need increased stimulation to get there. Again, penile atrophy can occur. Again, if the erections aren't occurring, just like with our bodies, if we don't exercise our bodies on a regular basis, our bodies get deconditioned. The same thing happens with the penis. And the other additional effects that can happen with ADT is things like fatigue, emotional changes, weight gain, hot flashes, loss of muscle mass, breast enlargement, and also sensitivity. So remember, what's really important, the factors that are contributing to the changes with erectile response can be post-surgical inflammation that leads to what I talked about neuropraxia, which is a shock of the nerves. Of the cavernous nerves, right? So that's neuropraxia. Next thing, we have a cutting of the pudendal arteries can decrease arterial blood flow, which leads to hypoxia, which is known as decreasing the amount of oxygen that's being carried into the penis, and apoptosis is actually cell death. Okay, because if there isn't the oxygen coming in, the cells will die, right? The chronic loss of erection leads to decrease of blood flow, cavernoso smooth muscle fibrosis, apoptosis, collagen deposits, and which can lead to veno-occlusive dysfunction. So basically what that's saying is that if you're not getting erections, the tissue becomes less elastic. Okay? So again, when blood is trying to come in, it can accommodate for that venous occlusive mechanism, so the blood won't stay in the penis. And then, of course, if there's changes with the different hormones or the neurotransmitters, again, that can affect part of the erectile response as well. Okay. So I wanted to put a little slide in here about fertility, because nowadays, sometimes men are getting diagnosed earlier and earlier with prostate cancer. So sometimes they don't think about, well, how can this actually impact fertility? So I wanted to talk a little bit about that. So basically, prostate cancer treatments can affect a man's fertility. When the prostate is removed, like I said before, there is no more ejaculatory fluid, and basically the ejaculatory fluid is the substance that carries the sperm. When we think about brachytherapy, it can preserve fertility, but over time the amount of ejaculatory fluid will decrease. With external beam radiation, that actually can damage the testes, and that's exactly where the sperm is being reproduced, or produced, I should say. There are still methods that can be used to take sperm out of the body, either through part of the reproductive duct pathway or through the testicles. But I think if a man is considering fertility in the future and he's going to be having prostate cancer treatment, it's very important to bank sperm, basically freezing sperm, and again, not just one sample, but a couple samples for sure. Okay. So now I wanted to talk about penile rehabilitation. So does anybody understand why a man has what is called nocturnal or morning erections? Does anybody understand? Well, I'm actually quite jealous about this, because the penis has its own exercise program. A man will sleep and he might have 3 to 6 erections during the night. They're not sexually induced. It's a biological process of how the body works to get blood into the penis, keeping the corpus cavernosum healthy. Like, I wish when I slept, my abs worked out. They don't. So again, with prostate cancer treatments, a lot of times that mechanism is wiped out, right? So if a man's not having sexual erections and he's not having the nocturnal or the morning erections, that's where we see that the changes can happen with the penis, the structures, and that will affect erections in the future. So basically, when we think about penile rehabilitation, it is physio for the penis. Okay. The question here, how long does penile rehabilitation go on for? Well, it goes on for, if a man wants to have erections for penetration and sexual activity, and he's not getting natural erections, then you would want to continue on with penile rehabilitation. Or if the man's natural erections recover, then you don't have to continue on with penile rehabilitation. How often is it done? Basically, like I mentioned before, sometimes men would have between 3 to 6 erections during the night, and then that's not even including their sexual erections. So what we say, the minimal baseline for penile rehabilitation is creating at least 3 erections per week. Okay? And the more blood that comes into the penis, like giving a stronger erection, the better that is. So what's really important is being proactive and developing a plan. In the past, a lot of times doctors would say, you know what, just wait and see. Don't worry about it, just wait and see. But again, like that analogy that I used around exercise, if we don't exercise our bodies will decondition. If we don't exercise the penis will decondition. So that's something that's very important. Developing a plan. I know in some places, as soon as the catheter is removed, a man is given an intracavernous injection, right? A lot of places will say, we want you to do this. But part of our philosophy is that we want you to have a plan, but we also want you, and if you have a partner, to feel comfortable with that plan. Remember I talked about that degree of readiness, right? If I say, you need to do all this, but you're not ready for that, there's not gonna be any investment from you about that, right? Okay. So one of the things that can happen is that after surgery, sometimes men will be given a prescription for Cialis 5 milligrams daily, okay? And this is part of penile rehabilitation. A lot of times the men will get the prescription, or usually the partner will get the prescription, the man will see the prescription, they're like, they just had surgery, excuse me, but I'm just not ready for any type of sexual activity. So this, again, is something for penile rehabilitation. This is something that's helping to support the erectile bodies, okay? So again, it's dependent on whether or not there was nerve sparing. So that's another option to think about, or a point to think about. The other thing that is helpful for penile rehabilitation is actually using the vacuum erection device. Okay, so this is something that there's different types of vacuum erection devices that you can get. You can either get them from adult love shops, or you can get them from pharmacies or medical distribution centers, or online. So the big difference between the two is that the ones that are medically graded, they are regulated, meaning that they have a certain amount of millimeters of mercury used to help create negative pressure, to help draw blood into the penis to create the erection. So as part of penile rehabilitation, I think this is a good device. It's probably bringing in about 30% arterial blood, so that's blood that's rich in oxygen. But the main thing is that it's helping to fill the corpus cavernosum, right? And it's helping to keep even part of that penile length. In fact, the literature talks about using VED helps to keep maintain the length of the penis as well. So again, with using the vacuum erection device, if you went through Lou to learn about it, he would actually put a man on a 14-day protocol. So again, usually beginning to use a vacuum erection device might be at, say, the 8-week mark or the 12-week mark, depending on how, say, the surgery went, okay? And basically, because a man usually has not had any erections for that period, you say, for instance, 10 out of 10 is the strongest erection, 0 out of 10 is the weakest, and say, generally speaking, if a man had like a 7 or an 8 out of 10 before his prostate cancer treatment, he wouldn't want to go from 0 to 7 to 8 right away, especially not having erections for, like, say, a 3-month period. So again, you would go on a 14-day protocol to slowly build up the erection strength. So again, that is something that can be used as part of penile rehabilitation. The other element that can be used as penile rehabilitation is intracavernosal injections. Okay, this is where a needle is used to actually put a small amount of medication right into the corpus cavernosum. And again, that it helps to draw the blood in to create the erection. So another option. The other option that I say as part of penile rehabilitation is penile massage. Okay? A lot of times doctors will say things like, you know, John, it's really important that you do some stimulation or you masturbate. And that's totally fine. But the thing is, like, how a man might stimulate or how a partner might stimulate her partner's penis, there's lots of different ways. So when I talk about penile massage, what that means is like having lubricant, moving away from the body, supporting the penis, and then coming back in the body. So moving away, coming back in. And if that is something that helps with blood flow, that's important. Okay? The other reason why I say penile massage is because if a man is not getting the response that when he touches his penis, he's not getting erect, sometimes men feel uncomfortable, they don't want to touch themselves. Or a partner might not feel comfortable if they're in the lovemaking session and she's stroking the penis but it's not responding. It's like there's a whole bunch of different conversations that can go on in the head, like things like, is it me, what's happening, all that kind of stuff. So by doing the penile massage, either with the partner helping you or doing it by yourself, it helps you stay connected, okay, with yourself, with your body, and with your partner's body. So those are some of the elements that are important for penile massage. So this next, okay, so what I just want to review the factors that influence recovery of erections, okay? So one of the elements is age, for instance. If the younger the man, I find erections tend to recover faster. The other thing is whether or not there's any existing disease processes. So if a man has like high blood pressure or say diabetes, those elements can interfere again with the recovery of erections. Medications. If a man is on certain type of antihypertensive medications or even antidepressants, that can sometimes influence. Sometimes with antidepressants, they can affect part of even sexual drive. So it's not to say a man should not be taking antidepressants. It's just that if he is taking antidepressant that is having negative effects on his sexual health or sexual function, you can look at other types of antidepressants that I call that are more sex positive. The other thing to think about is if a man is smoking. Again, remember one of the elements I said that was very important for erections is healthy blood vessels. Smoking actually affects blood vessels. The other thing, pre-treatment sexual function. If a man was having challenges with maintaining erections beforehand, that still is a situation that has to be dealt with after prostate cancer treatment. The other thing is preservation of the neurovascular bundles, and also, like I've been talking about, maintaining the health of those erectile bodies, the corpus cavernosum. Okay. So this next section that I was going to go through, it actually talks about ways of helping to support erections for sexual activity. Okay? So basically the first one that we see here is constrictor bands. So constrictor bands is that, like I mentioned before, there's actually two parts to erection. One is creating the erection and one is maintaining the erection. So sometimes if that venous occlusive mechanism has been disrupted and a man cannot maintain the erection, they can actually use tension bands, right? There's these ones here, the top ones here, they're actually, they're medically graded tension bands, but you can get tension bands at love shops. I've even had men tell me that they've borrowed their partner's hair, cloth-covered hairband to use. If you do that, don't give it back. Just keep it for yourself. The other thing is that if you're using a tension band, it's very important to trim the pubic hairs. Unless you like pain, you should trim those pubic hairs. The other thing that's really important is using lubricant, because that makes it a lot easier for putting the tension band on and also removing it. This item here, this is actually called a venosil. And what a venosil does, it provides a little bit of tension at the base of the penis. And what that can do is that can help to occlude the urethra so that if there is climacturia, remember the release of urine at the time of orgasm, that can actually help to stop it. Same with the tension bands as well. The other thing that we have to help with erections is the different PG5 inhibitors. Now I didn't explain, but basically what these do is that they actually inhibit a certain enzyme within the body to allow testosterone to work with nitric oxide and other chemicals to help create the erection. So PD5 inhibitors They are reliant on testosterone, and they also are reliant on the cavernous nerves. So if those cavernous nerves that control the erections are missing or they're in shock, you're not going to get a response like with the PD5 inhibitors. If you're experimenting with the PD5 inhibitors, is that I would try at different stages of your recovery. So you just don't try it at whatever, week 8, and you try it, and if you're not getting the response, say, well, that said this is not going to work. You might be a better responder at the 9th month, okay? Basically, with the PD5 inhibitors, Viagra, Levitra, Staxin, they're considered to be short-acting PD5 inhibitors. So they're only in the body for maybe 4 to 8 hours, whereas Cialis, 20 milligrams, is in the body for up to 36 hours. If you're using any of the PD5 inhibitors, it's very important to have good sexual thoughts and sexual stimulation. You can't just take the pill and go read the newspaper and check, because nothing's going to happen. So you have to be really proactive. Always read the label. Viagra, for instance, if you take that with a nice piece of filet with béarnaise sauce and a beautiful glass of Merlot, it's going to delay how the body can utilize the Viagra. Okay. Staxin, it's a pill that dissolves on your tongue. A lot of times, you know, if a man is taking a low-dose Cialis, is that, did you check to see if these are upside down? But you told me that. If they're taking low-dose Cialis as part of their penile rehabilitation, they can actually combine the short-acting with the Cialis 5 milligrams. But if they decided that they wanted to try a higher dose of the Cialis, then you would hold this for at least 36 hours before resuming that dose. So it's very interesting. Prostate cancer has been around a long, long time. 1 in 8 men are going to have prostate cancer. And yet the protocols around penile rehabilitation stuff, it's still very much up in the air about what is the best protocol. When you think about the Cialis 5 milligrams daily as part of penile rehabilitation, our practice is we encourage men to be on this for at least 1 year. In Ontario, they encourage 2 years. This is a very expensive medication. In fact, we're trying to get this covered as part of the penile rehabilitation protocol, so men don't have to worry about the expense with this. In regards to using the other medications, if natural recovery comes back with the erections, you don't need these. But if this is something that helps to supplement or create an erection for sexual play, if that's what's wanted, then you would continue to use them. All right. So the other medication that we see out there is Stendra. The United States are being really greedy with this medication because they're not letting it come across the border, but it is one of the medications that is that men, it doesn't matter what you're eating, or you can even have up to 3 alcoholic beverages, and it's not going to affect how that medication is working for you. So again, with these PD5 inhibitors, again, arousal is needed. Periodically challenging yourself with these is important, and always ask for samples. Write that down. Always ask for samples because they're expensive. So the next element here is that this is called Muse. That's actually a cross section of the penis, and Muse is actually an intraurethral suppository. There's actually 3 elements. There's injections, there's the suppository, and there's gel. I don't have a slide for the gel. These are all the same kinds of medication, but they're coming in different types of forms. And basically what those medications do is that they help to, they do what is known as vasodilation. So they actually relax the smooth muscle within the penis to create the erection. So if a man is on ADT, or has low testosterone, or is missing the cavernous nerves, or the cavernous nerves are in shock, you will get a response with those 3 types of modalities, okay? So with this particular one, the suppository, I find the men in the UK love this product, and I think it's because they get it for free. But here, it's expensive. It's running maybe about $27 a suppository. I find the success rate has been probably around 30 to 40%. But some men who, say, have a needle phobia, they like this product. The next product, well, the vacuum erection device, I remember I sort of talked to you about this for penile rehabilitation, is that with this one, is that if you're using this for sexual play, what happens is that there's a tension band that actually is loaded at the end of the cylinder, so that when the erection is created, this is actually rolled off, and it actually sits at the base of the penis, okay? And so what it does, it actually locks the blood in the shaft of the penis. So the corpus cavernosum actually extends into the pelvis. So that's why we usually, when a man has an erection, the penis is moving away from the body because it's supported by this root part of the penis. So if you have a tension band on there, sometimes the blood in the root area, or the portion in the pelvis, that blood might get reabsorbed. So sometimes there might be a bit of a hinge effect that happens when using the vacuum erection device. And all that means is that if you are using this for penetration, is that you want to make sure that the penis goes in at least 50% wherever it's going before movement occurs. The other thing with the vacuum erection device, because it's bringing in 30% arterial blood, about 70% venous blood, there's a tendency for the penis to be a little bit darker in color, and it might be a little bit cooler to touch. Some couples are fine with that. And some couples, they don't like that coolness, so what they'll do is they'll take lubricant, warm the lubricant, test it first, massage that into the penis. Or some couples, they might be sexual in the shower, or some couples, they find that once they begin having penetration, that the partner's body tends to warm the penis as well. The key thing is that if you're using any type of tension band, do not leave it on for more than 30 minutes. So you don't roll over and fall asleep, because you will not be happy in the morning. Okay. So this is actually, this next diagram here, it's a nice picture kind of showing how the vacuum erection device, or VED, can be used. I wouldn't necessarily recommend this type of vacuum erection device, just because with the extension tube there, sometimes it's harder to get that the pressure up to help to create that erection. But what you can see is once you can see where the tension band is. Once the erection is created, the tension band is released and sitting at the base of the penis, and then removed afterwards. And again, with the vacuum erection device, it's not reliant on testosterone, it's not reliant on cavernous nerves. So if you're using this product, again, it's 80 to 90% successful. So the next one that I wanted to talk about was the injections. And the injections are actually very, very successful. They're about 90% successful. They're considered to be the gold standard. But a lot of times, men don't feel comfortable with putting a needle in the penis for various reasons. And so I actually do the training for the injections, and I have a lot of men that have gone to injections, and once they've gone through the training process, they actually are, they're surprised that they didn't go to it sooner. Because the injection itself is not really, it doesn't cause pain unless you hit a nerve ending, and there's lots of different types of medications that can be used to create the erections. And like I said before, is that with the injections, it's not reliant on the testosterone or the cavernous nerves. The other thing about these injections is that cost-wise is quite economical compared to the pricing of the vacuum erection device or the pills. And the other thing that's really a bonus with this is that we've actually gotten a special authority approval for this type of medication. So men who've had neurological changes to their erections, such as prostate cancer treatment or spinal cord injury or multiple sclerosis, they can get approval for this medication, and depending what their status is with pharmacare, that they can potentially get the cost covered as well. So that's something that's important. So usually when you're using the injections, you only have to inject on one side of the penis. Usually the erection will occur within between 5 to 20 minutes, and the goal is to have the erection last between 30 to 60 minutes. I find that this is creating more of a natural looking erection because it's bringing in more of the balance between the venous and the arterial blood. And again, that's actually the corpus cavernosum right there. Okay. So this next picture I just wanted to show you. This is actually a penile brace. It's called the elator. It's not something that facilitates recovery of erections, but it's something that can support an erection. Okay. And the product itself is actually coming out of the States. If you go to the website, you can actually request an educational DVD, a free educational DVD. But again, one of the things that we find is keeping an open mind about possibilities, including this. This is actually a prosthetic penis with a harness. When I first started in this role, I remember reading an article about a man who had had prostatectomy, radiation therapy, and androgen deprivation therapy, and he lost his natural ability to have erections. But he missed the closeness that he experienced through penetration with his wife. And so he and his wife began to experiment with this, and it was very satisfying for them. In fact, with this particular harness, this is actually called the Deuce from Spare Parts, it actually has two openings in the bottom. The first opening actually houses the prosthetic penis, and the second opening actually allows for the men's genitals to come through. So with a particular couple, when they were doing penetration, with the movements that he was doing, the wife was actually stimulating the penis with the movements that he was doing, so his brain interpreted that he was actually doing the penetration. So it was something that for them it was very surprising, but it was something that was very, very satisfying for both of them. So again, it's kind of like, when you're looking at sexual adaptation, like redesigning your sexual life, there's different opportunities around that. And the other thing is about the brain. The brain is our biggest sex organ, and it's amazing how it kind of assesses scenarios, different situations. There's another article I was reading about a woman who there's a prosthetic arm in her real arm. So she was looking at this mirror system, and her real arm is being stroked, and she says, "You're stroking my arm." And then the prosthetic arm is being stroked, and she goes, "You're stroking my arm." So again, how the brain interprets situations is very influential. The other thing that we have here is penile implants. And a lot of times when we think about the different types of interventions for supporting erections, a lot of times surgeons would want individuals to experiment with these other types of interventions first before going to having a penile implant surgically implanted. Of the types that I normally see, it's usually this middle one that's actually a 3-piece type of implant. Basically, there's a reservoir that sits in the pelvis that contains fluid. There's an activation device that sits in the scrotal sac. Once this is activated, it allows the fluid to come in to fill the chambers, which actually replace the corpus cavernosum to help create the erection. Okay, so the question here is the options for erections. Like, how do you approach these? And basically, it's personal preference for you and your partner, if you have a partner. And one of the things I find is that people might change their minds as they're going through the recovery process. So again, keeping an open mind, which is important. Re-challenging yourself with the different types of options, keeping a journal, and sometimes even like sexualizing the options. I've had couples where, like, say if they've actually named their pumps. Or, sometimes what they'll do is if they're using injections, they'll have a preloaded syringe and they'll incorporate it into their sexual play. So, and this is something where you begin to have conversations about what feels comfortable. What are your judgments or your thoughts around the different interventions, and how might this be maybe part of your sexual life? So one of the things that we find is intimacy in other ways. When you think about a lot of times couples, they'll have a sexual history together. They might have been together for a long, long time. And a lot of times I'll find is that couples might have a pattern of how they're sexual. And there's nothing wrong with having a pattern. Like, why change something that's giving you pleasure, right? So again, this experience kind of creates that opportunity for changing. The communication part is huge, and sometimes people have never really talked about their sexual lives with each other. In fact, if they're choosing to be sexual, they might do it through nonverbal ways, like a touch or a look or gesture or whatever, so you don't have to really talk about it. So beginning to talk about it, that's something that we help individuals learn how to do. Okay, looking at a lot of times when I'm doing my assessment, I'll ask about, sexual activity? Is it primarily intercourse focused, or is there, other sexual activities that are done? So again, if a couple are primarily focused on intercourse, this is an opportunity to look at, different ways of having non-penetrative sexual activities. Recognizing the different dimensions of intimacy, right? So again, not just the sexual, but the emotional intimacy and the relational intimacy. And doing that check-in with each other, because sometimes we just, no matter how long you've been together, you can never really read each other's mind, right? So again, this is an opportunity to redesign your sexual life, and it's really, really important to remember those principles that are as helpful is acceptance, patience, persistence, and flexibility. And one of the things that we find that contribute to a positive sexual adaptation is managing loss and grief, sharing similar values and goals, looking at bringing in new types of activities that can be facilitating different sexual expression and connection, and also embracing the different dimensions of intimacy. Okay. So again, the benefits of intimacy: it allows connection, not just with your partner, but also with yourself. It actually increases circulations, it strengthens, it relaxes muscles, creates pleasure and relieves pain, fatigue, and stress, reassures love, appreciation, and attraction. It can distracts from the challenges of cancer and creates feelings of safety and security. And it helps you sleep, more so for some than others. We're done.
Yeah.
You can go.
Thank you.
Thank you. Thanks, guys.